and welcome to today's Cardiac Wire webinar on using Ultrafast coronary CTA with new AI tools in partnership with Arineta, South Tampa Cardiology, and Connected Cardiovascular Care Associates. My name is Victor Zarev, and I'm the Senior Editor of Cardiac Wire. We've got a great program for you today, and we're going to start with two presentations about how using coronary CTA in your cardiology practice can help improve your diagnosis and detection of coronary artery disease while moving complex imaging out of the hospital and improving patient access. Then we'll open up to questions in the second half of the webinar, so make sure to use the Q&A button to ask your questions for our presenters. A little bit about our two panelists before we get into it. Today we're joined by Dr. Tony Das, MD, and Dr. Alberto Morales, MD. Dr. Das is a practicing cardiologist and the CEO and founder of Connected Cardiovascular Care Associates. Dr. Morales is also a practicing cardiologist and the founder of South Tampa Cardiology. With those introductions, let's get right into Dr. Morales' presentation on the truth about CAD and why we miss so much disease.
Thank you, Victor. Thank you, Arineta and Cardiac Wire, for inviting me today to speak to you this afternoon. Welcome, everybody. My name is Alberto Morales. I am in Tampa, Florida, South Tampa Cardiology, and my specialty, and these are my disclosures, we are a outpatient focused preventative cardiology practice, and I have a specialty in advanced cardiac imaging, and there we scan about 4,000 to 5,000 CTs a year. And what I can tell you is I've been in practice now for about 15 years, and what I can tell you is the first 10 to 11 years of my practice, I used the hospital scanner to sort of do my advanced imaging, and there we had a 64 and a 128 slice. And what I can tell you that my first 10, 11 years of reading is very different than my last four. I used to call a lot of normal CT scans. So I think 64, 128, and typical CT scanners from hospitals, you're able to really do a good job with stenosis, but you miss a lot of plaque that's soft, and you get a lot of false reassurance. And what I can tell you is in the last 4 years, we moved on to an Arineta cardiograph initially, and with some upgrades, changed it to a spotlight. And the whole interpretation scheme changed for me. Higher resolution. Now I'm able to see non-calcified plaque, and I'll go over some of that with you today. So this is our cardiograph that became a spotlight in our office, and we installed it toward the end of 2022. And just absolute superb imaging. 560 slice, it can capture the entire heart with one beat. Super fast rotation speed at 0.24, 24 seconds. You're basically able to freeze coronaries and see things that I was never able to see with inferior technology. And spatial resolution at 0.2, 0.5. So what I can tell you is from my initial experience, instantly when we got the Arineta Spotlight, we were able to reduce our contrast load by more than 50%. Now we're typically average 50 to 60 cc's per study. And our radiation dose went from 14 to 40 millisieverts down to about 3 to 4 millisieverts. So on average, about 3.5. So the quality of the image is superb. You're able to see these, this is a scan of a typical patient that using a 64 slice may have called normal, but with a scanner that is very robust, you're able to really freeze these coronary images and see detail in in very micro millimeters, so you can see plaque. So here's an example of a soft plaque, and you can have tools that sort of change the color of the fat around it so you can kind of appreciate it a little bit better. And so here's a typical patient, and you can see, if you look closely, you can see right in the wall there's this non-calcified soft plaque. And here's me kind of hovering over the fat and then hovering over the non-calcified component. And then we have tools like AI that we can really enhance the visualization of these plaques. And I use Clearly. I also use another company called Elucid. But here you can see these soft plaques. And you might ask, why? Why is it important to identify these plaques? So I'm going to go over in this presentation the 4 blind spots. We are typically a stenosis ischemia first as far as risk stratifying patients. I'm going to go over calcium scoring and what is the true power of a zero calcium score, and does it mean that patient is at low risk scores versus reality, and then I'll conclude with single snapshot, how we approach patients, whether we are following them longitudinally for disease or not. So this is a typical scenario in cardiology. We typically wait for somebody to have symptoms before we evaluate them. And you can go down various pathways, right? Stress testing, CT. I obviously prefer CT, but let's go over stress testing. How accurate is it? This is some data from Curry in 2014. This is almost 400,000 patients across over 1,100 hospitals. And all these patients essentially flunked their stress tests. Right. And so you would expect, if you take them to the cath lab, if a test was 100% accurate, that all 100% would have obstructive disease. And what you're finding here is 55%, 56%, 55, 55, is these are patients who have non-obstructive, meaning the purpose of the cath was to find obstructive disease, and we failed. So at this point, this is about as good as a coin flip. And so stress testing has a significant false positive, but what about the false negative? These are scans that obviously, if they're normal, we interpret that as the patient doesn't have any disease. But the actual data shows that around 30 to 40% of patients that we tell on a stress test are normal actually have significant obstructive disease. And let's imagine we're in a world where stress testing is 100% accurate and it doesn't miss any blockage over 50%. It still misses non-obstructive plaque. And you might ask, why is that important? So here's a typical day in a cardiology practice, and you're seeing two patients. Both of these patients have normal stress tests. And here's the cardiologist going over the stress test, congratulating them, telling them, your stress test is normal, you're low risk, this is good data. But what if you could see inside? What if you can actually see what's really going on inside? So patient one is obviously has no disease, whereas patient two has diffuse 50, 40% blockages all throughout. This is sort of a ticking time bomb. There's advanced plaque all throughout his arteries. This is someone very high risk. Again, you don't get to see that with a stress test. With a CT, you get to see this. So this is very important. And then the million-dollar question is, would you treat these patients the same? And the answer is no, absolutely not. But again, a stress test, you're not able to see what's going on. So and then the reality is, when we're performing a stress test, we're doing it in a patient who has symptoms. And the data is pretty clear that up to 50% of patients who have heart attacks, and even 50% of patients who die of a heart attack, had no prior warning symptoms, meaning no prior symptoms of heart disease and no diagnosis of heart disease before their event. So if we're waiting for symptoms, it's far too late, unfortunately, for far too many. And as far as non-obstructive plaques, what is this significant about them? This is data from 4 major trials: Iconic, Gotthard, Promise, Copenhagen. And they're looking at culprit lesions. Of the 476 patients, 476 lesions that caused a heart attack, they looked at what are their characteristics. And over 71% of them were non-obstructive. These are lesions that are less than 50%. Here's more data on other studies, some combined with Iconic, that looked at 484, and these are patients who had a CT, whether it was 6 months, a year, or up to 2 years, and they went back and looked at the lesions that led to it, and what they had in common, overwhelmingly, that they were non-obstructive. More than 75% of these lesions were non-obstructive. So, and then they were obviously inflamed and had characteristics of a risky plaque, such as low attenuation plaque. This is a type of plaque that is sort of intraplaque hemorrhaging and bleeding, and it's the precursor to a plaque rupture. And then obviously we can look at inflammation. So what this tells us is that plaques that rupture are biologically active and not necessarily obstructive. And so identifying patients who have CAD is critically important. And so these are just some examples of a culprit lesion that ruptured in a patient with a left circ 100%. Again, this is a very mild non-obstructive plaque. This is a result of medical noncompliance. This is a result of a patient with high Lp(a) who was managed appropriately, but again, has a very non-obstructive plaque of less than 25 that ruptured, and you can see it right here. And then here's another gentleman who was non-compliant, who had a proximal LAD taken to the cath lab that ruptured. Again, the initial CT showed a non-obstructive lesion. So what about calcium scoring? Calcium scoring it helps sort of change patients' management, right? And so what is the power of a zero calcium score? And so here's some examples. And here's a 38-year-old female who had a zero calcium score with no symptoms, but was, strongly wanted to have concerns, had multiple stress tests, and you can see she had a very tight proximal LAD occluded lesion. Here's a 50-year-old diabetic with mild shortness of breath, not on statins, who saw a cardiologist, had a normal nuclear stress test, and a zero calcium score. And as you can look here, you can see he's got significant multi-vessel obstructive disease in the LAD and the osteal LAD. This gentleman with a zero calcium score actually went on to have bypass surgery. So what is the relevance of a zero calcium score? Does that mean you do not have disease? So here's just data from my registry, the Tampa Inside Registry. We just looked at the last 1,000 patients that we've scanned with a zero calcium score. And what we found is well over 416, over 40% had plaque in their arteries, some of which had significant obstructive plaque. The SCAPIS trial, which is a Swedish trial that screened asymptomatic people up to 25,000, their data showed up to 40 to 50% of patients with a zero calcium score had plaque in their coronaries. And what is the power of a zero calcium score? I think there's a good warranty period for maybe 5 to 7 years. And then beyond that, more than 50% of patients start to calcify who were once zero calcified, had a zero CAC score before. So I think what's happening is that all these patients are being missed, and eventually they go on to develop calcification. And what these trials showed with Blaha and Medema and Okawosa was that the majority of all heart attacks that are occurring, roughly 25% occur in patients with zero calcium score. So it doesn't negate risk, and it doesn't mean you don't have disease. What about traditional risk factors that we looked at? All these surrogate markers, LDL, just looking at this, which is what we do in our cardiology practice all the time, up to it, just having these markers and not having them does not explain more than 50% of cardiac events. Here's, I think we've all heard of the Smurf list. These are patients with no standard modifiable risk factors, right? They don't smoke, they don't have hypertension, they don't have high cholesterol, they eat well. And yet we all know, or at least everyone has been touched upon someone who has died of a heart attack, or at least had a heart attack that we thought was healthy. So these are healthy people population, and yet up to 25% of all heart attacks that occur are occurring in these in these people that we don't have anything we can necessarily control. Possibly LP(a) is playing a significant role here. Here's a nice MESA registry cohort, almost 7,000 patients that were followed for 10 years. And prior to this, they labeled each into, based on these risk calculators, PREVENT, SCORE, ASCVD, and they labeled them as high risk, intermediate risk, and low risk. And you would think that the high risk patients that we've determined based on this risk calculator would have the majority of events. As a matter of fact, the low to intermediate risk had the majority, overwhelming 82% of the events. And up to 54% more heart attacks occurred in the low risk compared to the high risk. So again, these risk calculators are not very accurate, and so we need better tools. And so these blind spots, we're shifting, and I think there's a new frontier of preventative cardiology where we're shifting from the oculostenotic, or the ischemia is the risk, when we know more than 70% of heart attacks occur in these non-obstructive plaques. So the focus should be more biologically active, not blocked as the risk. And you can only do that by identifying who has plaque, who has risky plaque. Zero calcium score does not mean no plaque. Up to 50% of patients with a zero calcium score actually have plaque, and up to 25% of patients with a zero calcium score actually have heart attacks. So think of calcium score more as a scar detector, but not a risk detector. risk scores versus reality. Again, risk scores, they help us in predicting probability, but again, only imaging actually reveals disease. And then this single snapshot longitudinal tracking, typically in cardiology, we image once and then we never look again. And so think about what paradigms in cancer treatment. We've gone from breast examination to mammography, fecal occult to colonoscopy, chest x-rays to lung screening. And where are we in cardiology? We're still using surrogates, even though, up to 25% of patients who are healthy and don't have any, and up to 70% of patients with normal cholesterol have heart attacks. We wait for symptoms, yet we know 50% of people have, may die before the onset of symptoms. And then, we miss plaques with stress testing that are non-obstructive, which are the risky plaques. And so think of using CT sort of as your virtual histology, right? If you did a mammography or a colonoscopy, right? The colon, you do a colonoscopy, you find a polyp, you cut the polyp out, that you evaluate it. Well, that's the same thing as a CT. Now you've evaluated the plaque, you've looked at it, you see it, right? Well, what does the gastroenterologist do? They usually send that polyp to histology, right? So that they can get all that information about risk inside of it. Does it have invasion of the stroma? Is this cancerous? Well, think of CT as your virtual biopsy, and then this AI tools to sort of help you decide who's at risk, which are the risky plaques, which are these non-calcified plaques, and which are the stable plaques, which are more the calcified plaques. So I'm going to end with a case and share with you. So this is a 57-year-old gentleman who's asymptomatic, hypertension, hyperlipidemia. He's adopted, doesn't know anything of his family. His prior workup, he's seen cardiologists in the past. He's had 2 zero calcium score tests. He's had prior normal stress testing, no symptoms. Again, this is his labs. He's got what can be considered a normal LDL. We didn't have his Lp(a) at the time, didn't have his A1C. This is a typical board question would be, do nothing different. Well, we did a CT. And what we found was a very high-grade proximal LAD lesion. Again, 70% with a 0 calcium score. Again, everything in the book would have failed him if we hadn't done imaging first, right? And so using the AI, clearly we're able to generate that this plaque is very non-calcified, risky. And when we put the color on it, you can see as you zoom in, yellow is non-calcified, and then you got this red dot, which is low attenuation plaque. This is very risky plaque. This is a plaque that I considered very risky and vulnerable. When we applied the ischemia, patient was also ischemic in there. Again, this is an asymptomatic patient, so most of us don't pass through this channel. So we talked to him about options, and we managed him very aggressively. We started him on a statin, put him on 10 of Crestor, bumped it up to 20, put him on a PCSK9. Initially put him on DAPT, and then later changed it to just aspirin. We were able to get his LDL from 108 to -10. Lp(a) came back mildly elevated. This is probably higher before PCSK9. And then because of his risky plaque, we decided to scan him in 6 months. And in just 6 months, you can see already his plaque has already reduced down to less than 50% in just 6 months. Here's before, a 70% lesion, and then 50% in 6 months. We're able to reduce his percent stenosis from 70 down to 50. And then when you evaluate with the AI, where you're able to actually look at the plaque characteristics, you can see that red dot is gone. And so here, and then we also were able to resolve his ischemia. So he went from ischemia, a high percent stenosis, ischemic looking lesion, to a non-obstructive, non-ischemic lesion in just 6 months. And when you compare the images side by side, you can see up here, you can see before and after. And as you zoom in, you can see this red dot is completely gone and the lumen is much more open. And then you can take it a step further and you can look at these plaque metrics, and you can see how much plaque volume he had before and after. So he increased by 16, and we attribute that to ongoing treatment and slight increase during this period of 6 months. But the most important characteristics is we were able to take his risky plaque and completely resolve it. We were able to take obstructive lesions and resolve that down to 50%. And then when we scanned him a year later, you could see that the plaque remains significantly reduced, less than 50%. And as you look at his plaque over time, you can see that we have essentially shut down plaque progression from baseline. As you can see here, we've essentially no change, and he continues to have no change in risk, and his percent stenosis remains unchanged. So again, single snapshot, no longitudinal tracking. One scan shows disease. However, we don't typically track patients, and so we're not really able to be sure that treatment is working for them. And so the game changer now is the ability to have advanced technology where you can provide very safe, low amounts of contrast, low amounts of radiation, where you can track patients over time and provide treatment success that's tailored to the patient. A recent article came out in the Lancet for Call to Change, which talks about rethinking coronary artery disease as a chronic disease, and we don't miss disease because it isn't there. We miss it because we're not looking for it with the right tools. And with this modern advancement in technology, where we have amazing scanners such as the Arineta Spotlight, advanced tools like AI, we can now perform serial monitoring, and we can see, treat, and see like never before. And with that, I will conclude my presentation. Thank you very much.
Dr. Morales, thank you so much for that presentation. Now let's hear from Dr. Das on transforming cardiac imaging and Arineta's CT in private practice.
Thank you, Victor. Let me go ahead and take over the screen here. Okay, hopefully you're able to see the screen. All right, so my job over the next 15 minutes or so is to help you with some real-world cases. Dr. Morales, that was an outstanding presentation. I think the thing that's so confusing to patients is essentially the idea of that they have a friend or themselves has an event, myocardial infarction or otherwise, and they don't really have a lot of risk factors because they had a stress test done, they've had one done for years, and they've looked okay. And so I think the concept here is that until you know more about the underlying anatomy, you won't make as good of decisions as you can if you have that information. So let's talk a little bit about how we've gotten to where we are now. So the historical challenge, as you previously pointed out for your first 11 years, was that for decades, state-of-the-art CT scanners were essentially in hospitals. The private practices really couldn't afford a $2 to $3 million system, and this cost barrier was probably one of the main reasons. In addition to that, many of the CT scanners in hospital systems were sort of multifunctional. They were there to do liver scans, to do other types of scans, soft tissue abnormalities, etc. But when you focus particularly on the cardiac sector, you want a high resolution, single breath hold kind of scanner that really focuses on the heart. And that's what we now have access to. So I think that was part of the traditional concept of not really having these scanners accessible for practices outside the hospital. So what's happened since then? So a little bit of a new era. I think that the idea is that companies have started to develop CT scanning technology specifically for cardiovascular purposes. And our Arineta scanner, kind of like Dr. Morales' Arineta scanner, is focused primarily on identifying cardiac and vascular conditions at a very high sensitivity and specificity. Also, companies have now realized that they may need to use other models other than paying for a $3 million CT scanner, coming up with ways that practices can actually partner with these industry folks and use some flexible financing options. If we use this pay-per-use model in our practice, it really eliminates the sort of big upfront cost. The reduced operating costs, because these modern scanners are much more efficient, lower radiation, and we can get throughput pretty significant in these patients. And in our compact design, we can put them right inside of our practice. In fact, we did this a couple of Octobers ago, and you can see this is the live pictures from the installation of our scanner. We're not on the first floor. You can see we're on the third floor. A crane was brought in, 4 windows were taken out, and the scanner was brought in through the window. And the size of the scanner and the footprint allowed us to put this into a room that's roughly 16 by 14, and we can do scans right inside our office. So a couple of things changed to be able to give us access to this, sort of democratizing the concept of access to CT scanning, which is important also because at the time we got this scanner, the wait time to get a cardiac CT scan done in the hospital was at least 1 month, and in some hospitals was up to 2 months. The benefits of these type of scanners, particularly the one that we have, is its ultra-fast acquisition. Dr. Morales did a very nice job of talking about the superior resolution and how fast in a single heartbeat it gives you those images, and you can see the quality of these images. This is just an AI analysis here, which is not the actual scanner. And there are limitations with the alternatives that we use to identify whether patients have coronary disease or not. Clearly, sensitivity challenges. If a patient has multivessel disease, nuclear stress scanning may underappreciate that, and we see examples of that, and I'm going to give you some of those in the following portions of this talk. Specificity is also important, which is false positive rates, right? I'm an interventional cardiologist, so one of the things that I do is put catheters in patients to identify the gold standard of whether they have coronary disease or not. And the more I'm working with my colleagues here in our practice that are expert imagers like Dr. McPherson and Dr. Rahman, what we realize is that, hey, they pick up coronary disease way better than we do in the cardiac cath lab. And they give us not only anatomical consideration, which is what we thought CT scanning did, but also with these new AI programs, functional considerations of what the plaque really is, how it's behaving, and really potentially whether we should intervene on those plaques or do as Dr. Morales did in his case, use very high intensity reversing agents, lipid lowering, et cetera, and improve that plaque and reduce the progression. I thought that was a fascinating case. And in addition to that, the guidelines have changed, right? So once upon a time, it was difficult for us to even get CT scans approved. And now, since 2019, the European guidelines label CCTA as a class 1 recommendation for patients with stable chest pain. So we know that these are patients who we're going to do well with if we end up evaluating them. In 2020, the American College of Cardiology also adopted this CT first approach. And our current practice now is when we have a patient that we want to understand both anatomy and physiology and remain non-invasive or minimally invasive, we want to do this CT first program. So you can see how the adoption has actually followed the access for these high quality scanners, and now the guidelines actually suggest this is the way to go. In addition to that, we have not only the anatomic considerations, but we now have physiologic considerations that are given to us through these imaging tools. There was a nice couple of examples that we saw just a few minutes ago, looking at clearly the plaque analysis program, AI powered to give plaque burden, composition of plaque, and vulnerability. These are so useful in our daily practice. And now we have 2 other imaging options as well. Heart flow, which gives us computational flow analysis, can tell us exactly what is the likelihood that a lesion that at least looks on CT as significant has hemodynamic significance as well. And the location of those also helps us to guide our evaluation and treatment. I'll show you some examples of that. And Elucid kind of puts those 2 things together and then gives us kind of ground truth pathologic information that tells us, hey, this is maybe a high-risk plaque, kind of like the calcification schedules that we saw previously. So let me go through 5 or 6 examples here over the next 10 minutes and give you an idea of how we use this. Case 1 is a typical patient that we see, 40 years old, executive, has a high LP(a). So this patient has a family history of premature coronary disease, asymptomatic but very concerned about cardiac risk factors. This patient underwent a CCTA. Calcium score was only 45, had mild obstructive disease. You'd think you'd stop at that point, but the Clearly analysis suggests that there was a significant plaque volume, and the patient then opted to go on to high-intensity lipid lowering, dropping the LDL significantly to less than 50, and potentially avoided early intervention. This is the atherosclerotic plaque volume that the patient had, and just as we saw previously, these are things that can be followed. So if the patient has significant atheroma, the volume can be followed, and the reduction in plaque totality can be also reduced with aggressive intervention. This is another case in which we use this typically. The first one was prevention. This is a typical preoperative clearance. Patient has preoperative clearance done for an open vascular procedure, which we know is a high-risk procedure, also has an elevated Lp(a), also has an elevated LDL, history of coronary disease. Patient's asymptomatic but has cardiac risk factors. Patient had previously had a nuclear stress test, which was somewhat abnormal with apical ischemia, and a CT scan was performed. Calcium score was 145, but showed soft plaque. This patient ended up getting an angiogram done in our outpatient setting because what we found, it was a very focal lesion, able to be detected and be able to be treated in a very safe fashion. This is the nuclear scan. You can see a very significant abnormality in the stress portions, which is the upper portion of this image. The perfusion with rest is improved, which is a sign of ischemia with maybe some underlying scar. And the CCTA is followed by a heart flow analysis, and you can see that red portion of the LAD at 0.7, suggesting a significant lesion in the LAD. We knew that was the focal problem. Patient went to the cath lab. As you can see in the middle of your screen, a very tight lesion, critically tight lesion in a relatively asymptomatic patient that can be treated with a single coronary stent and with significant improvement in the outpatient lab. And that patient was able to go on to surgery for her vascular procedure within 3 months. Third case is how CCTA drives potentially moving to the hospital for complex cases. So the types of cases and the types of severity are identified by the CCTA. Here's an example. 83-year-old patient had previous carotid stent. I put an abdominal aortic stent graft in this patient 6 years ago, and he was complaining of shortness of breath. We knew that the right coronary was occluded, and at 83, we opted to treat that medically. Patient had a pretest probability, obviously, of coronary disease, which was high because he'd already been known to have it. Had a calcium score only performed outside of our facility, and that score was 1,590. The patient was then referred by their primary care to pulmonary because it was felt that their coronary disease was stable, never got a CCTA. Ultimately came back for follow-up, and we ended up doing a CCTA and found that there was very critical disease, and we knew that there was an occlusion of the right coronary. You can see on the right this heavily calcified image of the coronaries, and the LAD is almost subtotally occluded. And the nuclear scan on the left is not severely abnormal. You can see on the upper images, which is the stress, that there is an abnormality in the right coronary distribution, which we knew because of the occluded right coronary. But we also see that there's inferior and apical ischemia, which portends this LAD lesion may actually be important. The patient underwent an angiogram, and sure enough, this is an angiogram of the right coronary, which we can see is occluded. And you see septal perforators coming over to the LAD territory, and then this very heavily calcified proximal LAD stenosis, which would have been completely ignored in this 83-year-old patient, but had it been for CCTA, we did determine that this was important. We thought that the inferior ischemia was minimal and the anterior wall was the worst, and we ended up having to use a rotational atherectomy device to be able to open up this lesion, which was performed successfully with a single stent, and the patient was sent home the same day. In addition, what we know is that these AI tools are additive, and they add not only to the anatomy that we get from the CT, but they add to the physiology. So here's an example of a patient, 64 years old with diabetes, has mild anterior ischemia on nuclear scan and was managed medically. Now the patient is having some atypical symptoms and a CCTA is performed. And although they were medically compliant, the CCTA suggests a very significant lesion. And ultimately we added a heart flow analysis. As you can see, the orange to red change in the mid-LAD suggests that this is a probably pretty significant lesion. It's a 64-year-old patient. The patient's diabetic, and that's what gives them these atypical symptoms. And we identified this and trusted that this was probably pretty significant disease. So I took this patient to the cath lab, and that's what I found. And as Dr. Morales pointed out, sometimes the cath lab is the place we think is the gold standard location. As an interventional cardiologist, I'd like to believe that. But here, the lesion looked moderate, not severe, but the CT was clear, and the AI program on top of it was also clear. So intravascular ultrasound was performed, which suggested that the lesion was quite severe. This is not this patient's intravascular ultrasound, but it's an example of a moderate lesion that actually is quite severe. So a single stent placement in this artery ends up treating that area, and we added high-dose statin therapy to it as well. And you can see that that lesion, which was thought to be mild by angiogram but severe by CT, was actually severe. Next case is a patient that I really didn't want to do a procedure on. Patient's 86, has multiple comorbidities. Calcium score was elevated at 468, mostly LAD, was also some RCA calcification, high likelihood there was significant coronary disease, and the patient underwent a fractional flow evaluation. The beauty of this, a little bit different than clearly, is that it tells me exactly where the severity of the lesions really are. So here's the CCTA, and then there's also the plaque analysis, and what you see is most of the red and the orange colors, which is severe plaque, is really pretty distal. So the beauty of this is, even though we knew that there was disease, even though we knew that there was significant plaque burden, the majority of it was in distal vessels. So I left this patient alone, ended up just treating medically, and did not have to intervene with coronary angiography whatsoever. And the last case is a young patient, asymptomatic, seeking a second opinion, had a low calcium score, looking for reassurance, and had a CADS-RADS score that was above 20 with low calcium burden, and the CCTA actually showed a tight left main lesion. So again, completely changing what we think is our understanding of where coronary disease is in each individual patient, like Dr. Morales pointed out. So in just clinical outcomes, I think CCTA increases our diagnostic accuracy to a high degree, way over nuclear stress testing and other things. And a single test like this can allow us not to do any further testing, sometimes for a couple of years at a time. And it saves time, and patients are very satisfied at every level of disease, whether it's just the asymptomatic patient with a strong family history, or whether it's a patient that has critical coronary disease. Identifying where they sit on that spectrum and how aggressive to be with them is very useful. So implementation strategy for us has been, we planned on putting a CT scanner in. We identified our partnership with Arineta. We've prepared our facility, got our training done. We integrated it into the workflow. And you can see how each patient that I presented today would have been treated completely differently had we not had this tool to be able to use to really sway us in one direction or the other, whether to be more invasive or in some cases less invasive with these patients. And I think ultimately this allows us to just treat patients more broadly and more globally, which I'm thankful for. So ultimately, it enhances our patient care, it's grown our practice, and in general, it's basically allowed us to take level 1 guideline, evidence-based cardiac evaluation to each of our patients in an outpatient setting, and not wait for patients to have to go through the process at a hospital system where they might wait months or longer to be able to get this type of imaging done. So thank you very much for your attention, and I will go back to the program here.
Well, thank you, Dr. Das, for your presentation. We're now going to open to the audience's questions, and we'll start with this first one. It's pretty general, but what has been the biggest benefit the two of you have seen to moving CCTA into your own offices instead of relying on a hospital partner?
Alberto, I'll let you go for that first.
Yeah, I can start. So I think the biggest player here is just faster access, right? I think Tony, excellent presentation, by the way. Hospitals they get tied up, and it's not uncommon to have delays in getting your patients in up to 1 to 2 months. And so there was always this backlog and jam. And so once we were able to take a scanner into our practice, we were able to facilitate really quick reads. You can actually take a patient in for a visit, scan them the same day, and go over the results right at the same time. And so it's really facilitated faster clinical decision making at the level right there at the level of care. And with that, you end up getting better outcomes, right? So now you're able to take this patient who has to be flown all over the place, all over city, just trying to get one study and then follow up with this patient. You're able to do it all, achieve it all in one location, and it's all for the interest of the patient. So workflow efficiency is all improved with having your own scanner.
Yeah, I'll add to that. I mean, I think the other thing is that when you have a cardiac specific CT scanner, you get high quality images. This is a 560 slice CT scanner. It takes no time whatsoever to get the highest quality images. One of the things that there's a kind of a misnomer about is that any CT that does coronary CT is basically equivalent. And the fact of the matter is it's not. As Dr. Morales pointed out, many of the scanners at hospital systems were there to do different types of scans that are not cardiac only. They may be 64 slice still, they may be 128, they may be 256. We work at a heart hospital and we have high quality scanners there, but at general hospitals, that's actually not the case. So I think the quality of the scan really is a big feature too, because just like anything else, inadequate or inaccurate information coming out of a scan doesn't really help me with the patient like a really accurate scan would.
Thank you so much for that insight. Our next question here is a little bit more about the population side of what you guys do, but what are some of the population level changes you've seen across your patients when it comes to using CCTA for CAD diagnosis?
With that, I think one of the first things I noticed when I started with this CT scanner was, how low the radiation was and how we could extrapolate that and start screening and prevention. And so one of the first things we started doing was we started screening 50-year-olds. And the thought was these asymptomatic patients, I wouldn't find a lot of disease. And what I found was almost 80% of patients over the age of 50 actually have some form of plaque, whether it's mild stages or advanced stages. What also surprised me was how many patients, a good portion of them, had obstructive disease with really walking around with no symptoms. So we expanded that to 40-year-olds and now 30-year-olds, and we're seeing disease that is not really discussed in our prevalence statistics. And so as a result of that, I started creating a registry to screen and to follow patients. I'm seeing roughly about 40 to 45% of people between the age of 30 and 40 have heart disease. And so I think one of the first things is that astonished me is I went from a hospital scanner where the radiation is high, the contrast is high, and I'm doing strictly guideline driven, symptom based following. Screening or evaluating patients to more of a prevention strategy, see, treat, and see. And the thinking was that I wouldn't see a lot of disease in asymptomatic people, and it just wasn't the case. And so as a result, we got people flying in from all over the country just to get an evaluation to find out what their real risk is. And you'd be surprised how many of those patients have seen another cardiologist and had a stress test and were told they were normal and were, they're or told that they don't, or of the belief they don't have heart disease, and they walk out of there with a diagnosis of heart disease, which now dramatically changes their care, right? Now they're going to go on medicines. Now they're going to do, lifestyle. It's very different when you're able to show a patient what's going on. And so I think from a population standpoint, having a scanner like the Arineta, which allows me to do more with my patients that I wasn't able to do before.
I am curious a little bit, Dr. Morales, obviously asymptomatic patients are not necessarily covered. We also have plenty of patients who ask for the scanner and are willing to pay for that. Is that the process in which you go through there?
It is a purely patient selected process, cash
Gotcha.
pay. Absolutely.
I mean, it's really interesting to hear that there are so many patients who have faith in this technology to the point where they'll pay that cost themselves. Going a little bit more on the technology side from our audience here, we have a question. Have you used any AI algorithms with the Arineta scanner that you have in office? And could you give maybe the clinical use cases about that?
Yeah, we sort of described all of those in both of our presentations, but we have Clearly, which is an outstanding plaque analysis program that tells us the severity of plaque, the volume of plaque, and as that example that we saw earlier from Dr. Morales, you can actually follow the progression or regression of that plaque. It also has an ischemia tool that'll tell you whether the patient has, in a binary way, ischemia or non-ischemia. Heart flow, computational flow analysis, another AI program, we have that in our practice as well. We have the ability to then specifically identify where the flow dynamics of FFR are reduced, less than 0.8, and whether we choose to intervene or to treat medically. And the location, I showed a couple of examples where the lesions were distal, we decided not to do anything in a more elderly patient, or proximal lesions in a patient about to undergo a high-risk vascular surgical procedure that we were able to intervene on in an outpatient setting. So heart flow, and clearly we use on a regular basis. And Elucid, we're just now starting to use as it's just now coming through FDA approvals. And that's going to give us one more piece of information, because we're also a vascular shop. I do a lot of endovascular work, and so carotid and lower extremity, it gives us the examples in the carotid artery of patients that have high-risk plaque that could potentially lead to stroke. And those patients almost never have any pre-warning signs. So if we could get enough images into those algorithms, we'll continue to probably have some forward-looking ways of identifying patients who are at the highest risk for stroke with carotid disease. So we use all three of those, and hopefully we showed those examples during our presentations, but worth reiterating.
Going a little bit on
agree.
the AI side.
We use the same three. We just started using Elucid months ago, and very superb technology, and we enjoy the carotid plaque analysis, and we get a lot of information from that, mostly Clearly and Elucid.
So obviously those softwares, they have a benefit when they're used to a dedicated cardiac CT scanner, but could you guys maybe speak a little bit to some of the advantages that dedicated cardiac CT has over, say, for example, a whole body CT that's also used for heart imaging? I know Dr. Das kind of touched on this a little bit in his presentation.
Yeah, I mean, I'm an interventional cardiologist. I've got 7 other cardiologists and providers in my practice that we're focused on cardiac and vascular disease. And to do scans on, and we were asked this, and why don't you want to keep the machine busy, right? Doing lung scans. And the point is that you can keep this scan busy because as far as we can tell, everybody we see has a heart, and everybody that we image wants to know the highest specificity and sensitivity results from their cardiac scan only. We actually have a radiology group that we partner with that reads the portions of the scan that are outside the heart, just so we have that analysis, but we're not really focusing on anything outside. This is not a general, let me see if you have cancer or other issues. We pick up pulmonary nodules, we pick up aortic aneurysms, we pick up things that are in the cardiovascular space, but we're really focused on the thing that really hurts patients the most, and that is the lack of knowledge of whether they have cardiac disease or not, and we want to use the highest quality scanner to be able to do that.
I would agree. I am, as an advanced imager, I do vascular imaging as well, and we read carotids and vasculars, and I would say that we're speaking about this AI and Elucid, and Clearly the limitations of AI is really based on the limitations of your scanner. And so if your scanner is of inferior technology or low spatial resolution, lots of artifacts, then the AI is not going to be as superb and as elusive as you desire. And so having a sophisticated advanced imaging technology allows me to get superb imaging, and then it allows the AI to give the feedback that I'm looking for. So the better the scanner, the better the AI. And so I think they feed itself. And then as far as scanning outside, I know Arineta's has the footprint and the FDA clearance for lung screening, and that is something that a lot of other offices take advantage of, where you can do a calcium score and a lung screen all in one. It would help with ROI and facilitating multiple patients. We don't take advantage of. We don't do the lung screening. I don't have a radiologist. I read everything, so I mainly focus on cardiovascular.
Thank you so much for that background. This is a pretty interesting question from the audience. For those of us who are not very business savvy, could you talk a little bit about ways to bring this technology into our practice and to our patients? Where is it economically viable for the practice?
Well,
Go ahead, Tony.
I was going to say, I think that it kind of depends on what you think your cardiovascular volumes are. With a practice that's seeing just primarily cardiovascular disease only and not a general practice for other, internal medicine, et cetera. And Arineta actually has this pay-per-use model too. So until you understand what your volumes are, you have to agree to a certain base. But then after that, it can be very viable with an early buyout plan as well. And if they're still doing that plan, and that's one way to avoid the high capital costs. So this was a great way to bring it into our practice. And ultimately, I think it turned out to be a great partnership for us. Go ahead, Alberto.
So, just expanding on that, I agree. The key, I think the way, it depends on your practice and what you're using it for. As a preventative cardiologist, I use it to identify patients at risk, which, is basically, if you think about it, the leading cause of death for 40 and up is a heart attack. And if you combine suicides, homicides, and accidents in 30-year-olds, it's the second leading cause of death in a 30-year-old. So we screen, we manage aggressively, and then the other half of my practice is purely in advanced imaging, where a lot of physicians just send patients for imaging, and we perform echoes, ultrasounds, vascular imaging. So it just kind of depends on how you're going to use it and what are the tools, right? So it enables a very low radiation, low contrast profile that allows you to also serially track your patients. And so if you're in prevention like I am, this is a fantastic tool, because risk, I've just showed you four ways that we typically look at risk, and they fail us almost every time. So, the key is who has plaque, and that's what we should be following. And if you find plaque, that's what you should be treating and following. And so that's kind of how I use it, and I think that the investment in that, in addition to using these AI products, and the return of investment is pretty good. There's also a significant halo effect when it comes to patient referrals and so forth. So.
And kind of going on a second tangent with that question, we've talked a little bit about the financials, but I'm curious to both of you who've now established this technology in your practice, what do you think is the biggest barrier for most cardiology clinics out there that maybe want to adopt their own CT capabilities, but just haven't been able to yet?
Maybe they don't feel comfortable reading CT, right? So that's sort of a new technology, and so there's all kinds of young fellows that looking for jobs that are being trained in advanced CT. There's also all kinds of courses that you could take but I think that the biggest limitation and the fear is you're buying a piece of equipment and you're not sure how to how to interpret the data that comes with it. And so I think that's the biggest barrier. I think as we move forward, and we are fellowships are now training advanced cardiac imaging. I train 7 cardiology programs in my area, so I have 3 fellows that come every single month to my practice, and we train them in MRI, CT, 3D echoes, you name it. So I think that the training is there, it's picking up. And so I think one of the biggest barriers again is the ability to use the technology.
And also just, being comfortable that you have enough volume. If you think about the number of CTs that you use when you have to send it out, it's usually less because of the hassle factor for the patient, et cetera. And I think that we would love to have the technology more accessible. If I knew that I could order a CT on a patient and I didn't have one in my practice, and I could get done in the same day or the next day, I would probably be fine with just sending it out. I don't think that it probably would have never happened. I think this came, our desire to put a CT scanner in our office came with the guideline changes from 2019 in ESC and 2020 in the ACC, where this was going to be the future of how we were going to assess these patients. And as cardiologists, if I didn't have the tool that was the class 1 guideline tool for assessing the patient in a timely fashion, I felt like we weren't going to be doing it as well as we should be. And on top of that, I did not want to have a scanner in my office that I felt was inferior to something else in town. So we really partnered with a high quality, fast CT scanner that ultimately had the ability to have high enough quality scans that you could actually employ the AI tools on top of them. As Dr. Morales mentioned, there's no substitute for a good scan because you can't employ heart flow or Clearly or Elucid on a bad scan. They reject those scans. And the quality of our scans is such that we have very, very few ever rejected. And I think that that's the other piece here is that, we want to be able to use the highest quality technology. We want to be able to give the best images, and we want it to happen in a timely fashion. If I thought that could happen somewhere else, we probably would just have done it that way. But we saw the need, even in a town as big as Dallas, Texas. We had a few CT scanners that were doing heart flow and Clearly in other locations, and the backlog for them was at the time we ordered our first scanner. Now we have 2 scanners in our practice, but the first scanner we ordered, the backlog on those patients was over 2 months. So it became very obvious there was a need there.
Well, gentlemen, thank you so much for getting into all of that. We've officially run out of time, so I am very grateful for everybody who watched this webinar today, and I'm very grateful for your time. This is incredibly educational for myself and our audience. And thank you. I've been Victor. This is Cardiac Wire. Goodbye.
Thank you, everybody.